This video provides a comprehensive guide on the postoperative management of GERD and hiatal hernia surgery. We will cover complications, guidelines from ACG 2022-2025, and modern management strategies. Our learning objectives focus on three key areas: diagnostic mastery, surgical precision, and crisis management. We aim to optimize patient selection, compare fundoplication techniques, and manage acute and late complications. GERD is a significant health burden, with a global prevalence of 20% and an annual healthcare cost of $12 billion. It is the most common benign esophageal disorder, often requiring surgery when medical therapy fails. The pathophysiology of GERD involves both mechanical and anatomical failure. Mechanical failure includes an incompetent lower esophageal sphincter and transient LES relaxations. Anatomical failure is often due to a hiatal hernia, which prolongs acid exposure. Hiatal hernias are classified into four types. Type 1 is the sliding hernia, accounting for 95% of cases. Type 2 is a paraesophageal hernia. Type 3 is mixed, and Type 4 includes additional organs. The Hill classification of the gastroesophageal junction is vital for endoscopic assessment of the anti-reflux barrier integrity. Grades range from I, prominent fold, tight, to IV, no fold, hiatus always open. The Los Angeles classification grades esophagitis severity from A to D. According to ACG 2022 guidelines, LA grades C and D provide objective evidence necessary for surgical planning. Next, we review the diagnostic roadmap, which focuses on the preoperative workup and optimal patient selection for surgical intervention. Preoperative evaluation relies on endoscopy to assess esophagitis grade and hiatal anatomy. pH monitoring is the gold standard for confirming pathological acid exposure. Manometry is critical to rule out achalasia and assess peristaltic reserve. The Demeester score is a global calculation from 6 parameters of a 24-hour pH study. A score greater than 14.7 indicates the threshold for pathological reflux. High-resolution manometry is key for identifying risk factors. Crucial findings include ineffective esophageal motility, achalasia, which contraindicates fundoplication, and a hypotensive LES. The anatomical roadmap involves a barium esophagram. This study defines the hernia size and type, identifies a, quote, short esophagus, and detects associated strictures, providing a critical baseline for postoperative comparison. ACG 2022 guidelines define indications for surgery. These include refractory GERD despite optimal therapy, desire for definitive therapy due to PPI side effects, and large hiatal hernias with mechanical complications. Surgery should be avoided in certain conditions. These include BMI over 35 kilograms per meter squared due to high recurrence risk, achalasia, severe dysmotility, and unproven reflux without objective testing. We now transition to the surgical techniques, focusing on Nissen, Toupet, and the important role of gastric bypass in certain patient populations. Is Nissen fundoplication still the gold standard? Its technical keys include a 360-degree wrap of 1.5 to 2.0 centimeters over a large bougie. While it offers superior long-term reflux control, its drawbacks include a higher risk of gas bloat and dysphagia. Toupet fundoplication is considered the safer alternative. It is indicated for patients with ineffective esophageal motility or those at high risk for gas bloating. Data shows similar reflux control to Nissen with significantly less postoperative dysphagia. Door fundoplication, an anterior 180-degree wrap, is typically reserved for patients undergoing Heller myotomy for achalasia. It protects exposed esophageal mucosa and has the lowest risk of obstruction, but is less effective for severe primary GERD. For patients with BMI greater than 35, Roux-en-Y gastric bypass, RYGB, is the bariatric solution and is sometimes called the ultimate anti-reflux procedure. It diverts acid away from the esophagus, reduces intra-abdominal pressure, and fixes the hiatal hernia. Next, we will focus on acute complications, covering early postoperative crisis management. Pneumothorax and mediastinum can occur from direct pleural injury or CO2 diffusion during extensive dissection. Small cases are managed conservatively, while moderate to tension pneumothorax requires a pigtail catheter or chest tube. Acute postoperative bleeding can arise from short gastric vessels, the left gastric artery, or the splenic capsule. Signs include tachycardia and hypotension. Stable patients are monitored, while unstable patients require urgent relaparoscopy for hemostasis. Visceral perforation is a surgical emergency with a less than 1% incidence. Esophageal injury is often from bougie insertion, while gastric injury is from trocar placement. Diagnosis involves CT with oral contrast, and management requires urgent reoperation, repair, and drainage. Postoperative nausea and vomiting, or PONV, is a structural threat. Acute vomiting in the first 24 hours can disrupt crural sutures, leading to fundoplication failure. Prevention requires aggressive, multimodal antiemetics. We now shift our focus to late complications, which often include chronic issues and the, quote, failed fundoplication. Persistent chronic dysphagia has several causes, including a wrap that is too tight or a slipped Nissen. The management algorithm involves ruling out structural issues with a barium swallow, attempting dilation, and considering reoperation for structural revision. Gas bloat syndrome affects up to 10% of Nissen patients, characterized by the inability to belch and abdominal distension. Management includes dietary modification, prokinetics such as metoclopramide or erythromycin, and simethicone. A slipped fundoplication occurs when the wrap migrates down the stomach. This results in the paradoxical recurrence of both reflux and severe dysphagia. Diagnosis is made with a barium swallow, and the fix requires a redo fundoplication with complete mobilization. Hiatal hernia recurrence is the most common late complication. The risk significantly increases with initial hernia size greater than 5 centimeters. Recurrence presents with recurrent heartburn, chest pain, or respiratory symptoms. Mesh in hiatal repair can reduce short-term recurrence in large defects by reinforcing the crura. However, there is a risk of catastrophic mesh erosion, infection, and stricture, and SAGES suggest no long-term advantage. Mesh erosion is a surgical nightmare. Erosion into the esophageal lumen can cause gastroesophageal fistula or stricture. Evaluation involves endoscopy and Cort. Surgery typically requires mesh removal, debridement, and often a Roux-en-Y conversion. Cameron ulcers are linear gastric erosions found at the diaphragm level in about 5% of large hiatal hernias. The mechanism is mechanical friction, leading to occult GI bleeding and chronic iron deficiency anemia. Medical treatment for Cameron lesions is high-dose PPI therapy and iron supplementation, which is often effective. Surgical management is recommended for refractory cases involving hiatal hernia repair and fundoplication to eliminate mechanical friction. We now address the complex issue of failed fundoplication, including its classification and strategies for revision surgery. Structural failure of a fundoplication can be classified by anatomical deviation, such as wrap migration, wrap herniation, or a wrap that is too tight. Symptoms often include recurrent heartburn or dysphagia. Redo anti-reflux surgery requires careful planning. First, identify the failure mechanism using manometry or a swallow study. The takedown of the old wrap is the most dangerous step, carrying a risk of vagal nerve injury. A toupee wrap is often preferred for reoperation. Conversion to Roux-en-Y gastric bypass, RYGB, is the salvage procedure of choice for failed redo fundoplication, severe esophageal dysmotility, obese patients with recurrent failure, mesh-related issues, or gastroesophageal fistulas. Our next section covers Barrett's esophagus, focusing on the PROG C and M classification and modern management techniques. The PROG C and M grading system standardizes the length of Barrett's esophagus. C is the length of the circumferential segment, and M is the maximal length of the longest tongue. For example, C3M5 means a 3 centimeter circular segment with a 5 centimeter maximal tongue length. While fundoplication controls symptoms, evidence on its ability to regress Barrett's or prevent adenocarcinoma is controversial. Surveillance remains necessary postoperatively, but a combined approach of ablation and fundoplication is becoming the standard for high-risk cases. Vonoprazan, a potassium competitive acid blocker or PCAB, offers advantages over PPIs, including faster onset and meal-independent dosing. It demonstrates superior healing rates for severe LA-grade CD esophagitis. Magnetic augmentation using the Lynx device involves titanium beads that restore sphincter function without tissue wrapping. It allows easier belching and vomiting and is indicated for small hernias and normal motility. The robotic approach offers several surgical advantages, including superior visualization in the deep mediastinum and precise suturing with endo-wristed instruments, which leads to lower rates of esophageal injury in complex redo cases. We now conclude with a summary of the path to successful surgical outcomes and future directions. Surgical success relies on a critical checklist: This includes strict patient selection, ruling out achalasia with HRM, complete esophageal mobilization, tension-free crural repair, a floppy wrap, and aggressive antiemetic management.